Pertussis, or whooping cough, is a severe, potentially life-threatening disease caused by the bacteria Bordetella pertussis and is one of the most prevalent vaccine-preventable diseases in the United States. The classic presentation of pertussis occurs in unvaccinated children under the age of 10 years who develop paroxysms of cough followed by forced inspiratory efforts, a whoop, and post-tussive emesis. Supportive care is the mainstay of treatment for pertussis, although antimicrobial management with macrolides is recommended early in the course of the disease within 7 days of its onset and in high-risk individuals, such as infants and pregnant women. Symptomatic therapies, such as bronchodilators, corticosteroids, antitussive agents, and antihistamines, have not been proven to be effective for pertussis-related cough. Osteopathic manipulative treatment offers a potentially useful adjuvant to the traditional supportive care that is provided to patients with pertussis. Several key areas may be important for diagnosis and treatment. The diaphragm may be assessed as it is the main muscle of respiration and also facilitates venous and lymphatic return. Diaphragmatic dysfunction can occur as a primary dysfunction or as a result of dysfunction at or near the diaphragm's attachments, including ribs 6 through 12, lumbar spine vertebral bodies L1, 2, and 3, and the xiphoid process. The cervical spine may also be assessed as the diaphragm receives its innervation from the phrenic nerve, C3 through 5. Finally, one may assess the occipito-atlantal region, as vagus nerve afferents and efferents are an integral part of the cough reflex. Paroxysms of coughing may lead to somatic dysfunction of any of the areas listed, among others. This video will demonstrate the balanced ligamentous tension technique of the thoracic diaphragm, which is a passive technique and may be used in infants or children with pertussis. Begin by assessing in the supine position. It is important to note that compressive forces on the rib cage or diaphragm on infants and young children should be avoided. To assess this area, the physician places their hands around the patient's thorax, with the thumbs at the inferior costal margin anteriorly and the fingers on the thoracic vertebrae posteriorly. In this position, the physician can assess and monitor ribs 9 through 12, the thoracolumbar vertebrae, and the diaphragm during the patient's respiration. Note any areas of restriction or decreased motion. To treat the area, the physician maintains contact with the ribs and gently decompresses the costovertebral articulations of ribs 10, 11, and 12 while monitoring the response of the diaphragm. Without using any compression into the diaphragmatic tissues, the physician should create balanced tension, or even on all sides, throughout the dome of the diaphragm. You may accomplish this by moving the diaphragm superiorly, inferiorly, to the left, or to the right. This position is maintained until an improvement in function, motion, or change in tissue texture is noted. In this example, to create balanced tension in the tissues, I will move the tissues superiorly and to the left and hold for a release. Then I will reevaluate. Contraindications to this type of assessment and treatment include lower rib or vertebral fractures and malignancy, open wounds, incisions, or infection in the areas where the physician's hands are placed. Successful treatment should optimize respiratory biomechanics while facilitating venous and lymphatic return. This technique can be used with patients of all ages with pertussis and other respiratory illnesses, including young infants who are the most vulnerable. Assessing and treating the diaphragm in patients with illnesses like pertussis may aid in symptomatic and physiologic improvement.